Hello and welcome to the MASLD MASH Community Network meeting with Chantil Jeffreys. My name is Trisha and I will be your moderator this evening. I'm joined here virtually by our presenter, Chantil. There'll be an opportunity to ask questions live at the end of the presentation and network with the other participants. Now I'll pass things off to Chantil.
Hi, everyone, and welcome to this webcast from the MASLD MASH Community Network. My name is Chantil Jeffreys, as Trisha said, and I work as a nurse practitioner in clinical practice and clinical research at Gastro One, and this is part of One GI. As the participants on the call here, the ones I see now already know these things, but other people might not if they view this webcast later. I'm in the greater Memphis area, Memphis, Tennessee area, and I have more than 24 years experience in GI at the same practice. I'm also the APP clinical director with currently 31 direct reports that are all APPs. So education is kind of near and dear to my heart because I'm always trying to encourage the younger generation or the newer generation of GI APPs to learn more about different disease states. And MASLD and MASH are truly up-and-coming disease states that we need to know a lot more about. So let's get started with this discussion on MASLD pharmacotherapy. There will also be a question and answer period at the end. Feel free to put things into the chat if questions come up as I'm speaking, and we'll try to address those at the end. We'll work on those together and see what we come up with. Or you can ask the question live as it comes up. I forgot to turn my slides there. We got them though. If you're not registered, of course you all are, you can register for this meeting using the QR code. So currently available treatments for this metabolic management are sort of wide. They treat the different symptoms, the different disease states that go along with metabolic syndrome. We've all heard about weight loss as a big part of MASH, MASLD, and the metabolic syndrome. In the past, all we've really had to encourage people with, well, we've had medications for a long time, but we tried to encourage people with diet, physical activity, Mediterranean diets and things like that. We've also steadily improved our armamentarium of weight loss drugs. So now we have the GLPs, which were initially approved for the treatment of diabetes and have gone on to be approved for weight loss. There's also bariatric surgery that patients can consider in this class of weight loss in order to improve the metabolic syndrome. Type 2 diabetes is also an additional issue that goes along with MASH and MASLD, and there have been developing improvements for type 2 diabetes and to reduce cardiovascular risk in patients with MASLD. And this is an important thing, and this is one of the things I had to do common misconceptions related to liver health. And this is one of my big things is NAFLD and MASLD does not increase statin risk of drug-induced liver injury. So it's still sort of a school of thought that, people have abnormal liver enzymes, they need to stop their statin, when in fact we've learned that those people are even more importantly need their statin as part of treating the metabolic syndrome and improving their overall liver health. There are some liver-directed treatments that have been sort of bandied about and used, prior to us having some good, targeted MASH treatments. These include vitamin E, but the studies have shown that vitamin E actually increases in the risk of mortality and morbidity in patients with diabetes. So you don't, want to use vitamin E in our metabolic syndrome patients that also have type 2 diabetes. It has been in the past studied briefly in some small trials that vitamin E up to 800 IUs per day might improve liver fibrosis, but that's not really been reconfirmed throughout the years. And pioglitazone, that's a diabetes treatment that they've looked at to be a liver-directed treatment. However, one of the big drawbacks with that drug is it can induce weight gain, which is not what we want with our MASH and MASLD patients, because that can increase their risk of fibrosis and inflammation in the liver. So now we have Resmetirom, which is the only FDA-approved treatment that is a liver-directed treatment for MASH specifically. And these charts may say NASH, may say MASH. Just know that those terms are interchangeable. An important point, I think, to note here is weight loss. We know that works. We've seen in studies that it improves the fat scores and it also improves fibrosis. However, it's a very difficult thing to achieve. In some studies that they conducted, it was advised to achieve and maintain a 7 to 10% weight loss in order to improve the histology of the MASLD and MASH. But the resolution of MASH and MASLD actually, if this is sustained at 10%, can actually reduce their issues by about 80%, or 80% of patients can reduce their issues. We know from the studies as well and from clinical practice that not nearly 80% of our patients will be able to maintain and sustain a 10% of their body weight loss for an extended period of time. So it's good that we have additional treatments to help with this. So the GLP receptor agonists, they stimulate glucose-dependent insulin secretion, suppress glucagon, delay gastric emptying, and directly act on the hypothalamus to promote satiety and reduce energy intake. They're analogs of the gut-derived incretin hormone, and they do lower blood glucose and results in weight loss. So I know we've all heard the hype about these drugs. They were initially approved for type 2 diabetes, and they do have different names related to what they're approved for. So semaglutide was first approved for type 2 diabetes as Ozempic, and later was approved for weight loss under the name of Wegovy. Tirzepatide, which is a GLP-1 and a GIP, was originally approved for diabetes and called Mounjaro, and now for weight loss, it's called Zepbound. There's other GLPs, the liraglutide or Victoza. Oh, sorry, I sometimes really butcher these words, but that's because I'm a Southerner, and we just don't say things right half the time. But Victoza was approved for diabetes, and then later approved as Saxenda for weight loss. Then we have the Trulicity that's only approved for diabetes, and the Byetta that's approved for diabetes, but also has shown some weight loss in some of the patients, but it is not approved for weight loss or obesity. So what's the role of the GLPs in liver practices and GI practices? Semaglutide is currently under review by the FDA as a treatment for MASH. The data has been made available and it demonstrates strong benefits, but it's not yet on the labels. So if you try to order semaglutide for MASH, then you're not going to get that approved likely. And how did the GLPs affect GI providers, which most of us on this call today are GI providers? With the delayed gastric emptying, also it increases the risk of aspiration with anesthesia. So we have patients definitely stop their GLPs for 7 days before their scheduled procedures. And delayed gastric emptying, if you've ever treated a gastroparetic patient, you know what that does to a patient. Sometimes it can be extreme, sometimes it's manageable, but you need to know how to manage these side effects before you start prescribing these drugs to the patients. So back to the vitamin E, 800 units per day has been studied, as I said, in the small trial. They had the Pivens trial, was a landmark study showing that the vitamin E improved liver histology in non-diabetic adults with NAFLD, MASLD. And it can be indicated for patients with non-diabetic MASH as long as they don't have cirrhosis. There was about 43% effectiveness or in histology improvement in these patients studied. Not all patients responded, and you can't use in hypertensive or diabetic patients. So in 2023, the AASLD suggested that vitamin E may improve NASH in non-diabetics. Then in 2024, this joint society guidelines, including EASL, which is the European version of AASLD, they don't recommend the treatment of MASH, or they don't recommend vitamin E in the treatment of MASH because there's limited efficacy and potential risk that can occur. You can develop bleeding. There's prostate cancer concerns, and you definitely, before you prescribe or recommend this particular thing to patients, you want to discuss the potential risks and don't want them to take high doses. So the Pioglitazone, the dosage for this one is 30 to 45 milligrams per day. There is an indication to use it not on the package, but for MASH patients with or without type 2 diabetes. This Pivens trial that showed efficacy with the vitamin E also showed that there was no benefit of Pioglitazone over placebo in improvement of those histological features of MASH. But there were some benefits shown with Pioglitazone for secondary outcomes and improvement of cardiovascular risk, which is something that we really need to focus on in patients with MASH and MASLD. The safety concerns, the weight gain that I mentioned before, there's also risk of edema, bone fractures, especially in women, and there's an increased risk of bladder cancer in patients taking this drug long term. So on March 14th of 2024, a day that will go down in infamy, I guess, Resmetirom received FDA approval in conjunction with diet and exercise to treat adults that don't have cirrhosis, that have, at the time, NASH, because that's what the studies were conducted under that particular name. And the patients needed to have fibrosis of F2 or F3, F2 to F3. It's a thyroid hormone beta receptor agonist. It selectively binds with this thyroid beta receptor in the liver. So the physiological relationship between the thyroid and the liver is pretty fascinating. And, I never really thought much about the thyroid related to MASH or MASLD or any other liver issue until, these these programs and education have been coming out about how resmetirom works, and it makes a lot of sense, but it's not something as a general GI practitioner that I've thought about. I've heard an endocrinologist explain this in a very detailed and very high level manner. And it's fascinating because they knew this all along, and it's just not something we were looking at. So I'm glad somebody was smart enough to figure out that this would be a good treatment for MASH. So the important points of this slide include that thyroid hormone is regulated by the hypothalamic and pituitary activity. The thyroid hormones also regulate metabolic activities and a lot of systemic processes in our bodies. There are two major isoforms of the thyroid hormone receptors. There's the alpha and the beta. The beta is mainly in the liver. The alpha is in other organs, including the brain and the heart. Resmetirom activates those thyroid beta hormones in the hepatocytes and help to upregulate fatty oxidation and lipid metabolism, and help to break down excessive fat in the liver. It's really interesting how this works. It enhances the cholesterol efflux from the liver, from the mitochondria, and it helps to remove some of this unhealthy material that's in the mitochondria. Thereby, it indirectly reduces inflammation to the liver. It also has an anti-fibrotic action. It helps reduce liver fibrosis by decreasing the activation of the hepatic stellate cells that are responsible for that collagen deposition that we see with the scarring that happens in the liver. Welcome, Angela.
Thank you.
You're welcome. So this is the pivotal clinical trial that helped to get resmetirom accelerated approval for the treatment of MASH. It was the Maestro NASH, and Angela knows all about this one because she's been a part of this study for a few years now. She works over in our research department. So they trialed adult patients with biopsy-proven confirmed NASH and a fibrosis of stage of either F1B. They cut that one off pretty quickly because that arm filled up pretty quickly. And then F2 and F3. So 966 patients were randomized, and they were assigned to either resmetirom 80 milligrams, 100 milligrams, or placebo. There were two primary endpoints in this study. That was NASH resolution. So the patients had to have a reduction in the NAFLD activity score, which is a histological score that they use. It had to be greater than or equal to 2 points, and they had to have no worsening fibrosis. They also had to have an improvement or reduction in fibrosis by at least one stage with no worsening of the NAS score. So this was a twofold primary outcome or endpoint. So in the safety data for the Maestro-NASH trial, diarrhea and nausea were the most frequent side effects seen, and they were seen more frequently in the resmetirom-treated patients than placebo. But the incidence of serious adverse events was fairly similar across all trial groups. Resmetirom 80 and 100 milligrams were superior to placebo in respect to the NASH resolution and improvement of liver fibrosis by at least one stage. So practical considerations for managing MASH with resmetirom. The ideal patients for this treatment are adults that don't have cirrhosis and have MASH, and they have moderate to advanced liver fibrosis with stages F2 to F3. And it's only approved in conjunction with diet and exercise. There's not a specific diet or exercise plan recommended, but that is part of the treatment that should occur when you're using resmetirom. So resmetirom, there are some drug interactions. This first box is medications to avoid, and a lot of those are antivirals. There's clarithromycin. In the tolerated but resmetirom dose reductions, the clopidogrel and the antibiotic, also the risk of increased exposure due to resmetirom, those are like pioglitazone, and then like singulares there. And statin doses are allowed, but there are maximum statin doses allowed with the treatment of resmetirom for MASH. Pravastatin should be no higher than 40 milligrams, simvastatin 20, atorvastatin 40, and rosuvastatin should be at 20. These are fairly common doses that we see in our patients in clinic that have MASH. So most of the time you don't have to do any adjustments, but if they are on higher than these recommended doses, it's recommended to adjust them down before starting resmetirom. And the good thing is the patients don't necessarily need the higher doses when they're on this therapy, because this therapy actually reduces cholesterol levels and lipids in these patients. So practical considerations for managed MASH with resmetirom continues here. The duration of treatment and monitoring. So there's ongoing evaluation of the NASH trial. It's going to be a few years before we have this completed. So we don't know at this point the length of time people need to stay on this medication. We will likely need to restage fibrosis and steatosis with NITs, like the FibroScan, the MRI-PDFF, the ELF score. And expert panels are currently working on cut points and the timing for testing for patients on resmetirom, but there's nothing set in stone yet. Our societies haven't come out with a specific guideline, but more to come on that. So our question remains, the questions that remain. So widespread use of resmetirom will depend on insurance coverage, of course. We all face that on a daily basis. We need to clarify some of how often do we stage and what kind of lab tests that we need to do for monitoring. We'll need a duration of treatment recommendations, and when do we discontinue the treatments? Of course, if fibrosis levels are getting worse or liver enzymes are going up, that would be a key indication to stop therapy. Multiple agents are currently in clinical trials and will likely have more options in the very near future for treatment of MASH. So you can visit the GAP MASLD MASH Community Network for additional disease state education and a Rezdiffra webcast. Just need to go use this barcode, and you can go into there. And I'm going to send everybody that works for Gastro One, I'm going to send the link to this community network. I'll send you an email, and you can look these things up, and anybody can have access to this. So, any questions?